Good afternoon. Good afternoon. I hope I'm live. I hope you guys can hear me. Uh, I am so sorry I'm a little bit late. I would love if people can let me know whether they can hear me. I've been having some issues with my sound this afternoon, and this time I'm doing it all by myself. I don't have my 23-year-old daughter here helping me with my sound and my setup, so forgive me if it's a little bit disjointed this afternoon. My name is Lizette. I am actually an occupational therapist, and I have been an occupational therapist for about 30 years. I graduated from the University of Pretoria in South Africa in 1992, so you can do the math yourself. I've been in the United States since October 1993. My husband and I immigrated here from Pretoria, South Africa, and we currently live in Greenwood, South Carolina, and I decided to start just doing some live videos just to kind of do some education for people regarding dementia and to just become a little bit more visible. So I asked a couple questions earlier this week regarding any questions people may or may not have for questions they have about dementia, and I will try to answer them today. I hope to make this a weekly thing. I hope to make this something that is valuable to you in this group, to be able to just get information regarding dementia that you may not be able to get easily accessible at other places. I hope to do this for an hour, but depending on how my day goes and how my voice lasts, it may not be an hour today. I have had been struggling with my allergies, in case you can't hear that. Hi Eunice, I'm so glad. Can you hear me okay? Like I said, my daughter usually helps me with my sound, and I'm not entirely sure if my sound is working real well today, but how is South Africa today, Miss Eunice? And so back to me, a little bit about myself. I got into occupational therapy when I was a younger adult, obviously just graduated high school, and the reason I picked occupational therapy was it was the only degree course that actually combined the three things that I'm really good at: the sciences, psychology, and art. So if you don't know anything about occupational therapy in South Africa, we actually do a lot of activities and activity analysis. We had to do woodworking, we had to do things like basket weaving and all sorts of other things. And so I started my career out working in nursing homes, working as a traveling therapist. We lived in 11 different states in the span of 3 years. It was quite phenomenal. We got to travel a lot. We got to see a lot of different places, a lot of different people, meet a lot of different people. After a few years, I started to work in acute care and rehab hospitals, where I got a lot of background in spinal cord injury and head injuries, and really started my journey in truly loving working with people with cognitive impairment or difficulty with thinking. And then I started to realize that a lot of people I worked with were more afraid of having physical problems and not being able to go home. But the reason that a lot of people struggled to actually go home was because they couldn't think. If you can physically do something, but you cannot think, it becomes a very unsafe situation. And so I started to gravitate towards dementia and dementia care. And probably for the last, probably 15 years or so, I have started to specialize in dementia care. And most of I would say probably 80% of the people that I work with right now in home health have some level of dementia, either themselves or a loved one, or they're my patients themselves. So I do have a significant background in dementia care, and a significant love for people with dementia and their families, and a significant interest in being able to help people navigate this very difficult process and this very difficult journey that people are on when they first get a diagnosis of dementia. So some of the questions that I was given earlier this week, I'm going to slowly start to go through. I hope that I can, in the next weeks or so, start to invite some of my friends and colleagues who have an interest in dementia to be able to answer some questions, kind of go back and forth with people, and just, to make this a service for people in this group regarding how we can help serve you and help you with your needs. So if you have questions, please throw them in the comment box. If you can, show me that you're here, that would be wonderful. It's definitely a different way to do things when you're not used to doing this, especially when you're on your own. So we'll go with the flow. We'll see how it goes today. So anyway, Eunice, do you have any questions? I see you're still on. And then we can maybe start with your questions. And like I said, I do hope to start to have other people here talking with me instead of just me. And hopefully we can make this a weekly thing. So I'll give Miss Eunice a minute to think about it. So I'm going to start with just a quick little learning opportunity. I have my cheat sheet here just so I don't forget something, because, I'm human, and it is definitely something that makes you, more nervous when you're doing something new. So I wanted to talk real quick about just a quick little overview of executive functions. And the reason I want to talk about executive functions real quick is because a lot of the questions that I got, actually, when you understand executive functioning and how it works, will help you understand why your loved one is having some difficulty with some things. So if you think about it, executive functioning is the overarching umbrella term for a lot of different little things. It is our ability, people's ability, to inhibit and regulate our behavior. Mike, hi! Now you're making me really nervous. So to inhibit and regulate, self-regulate behavior. So what falls under executive functioning? Under executive functioning, we have the following things. We have our working memory, which we can talk about a little bit later if we want to. It includes things like time management. It includes emotional regulation, which is the one we're probably going to talk about the most today, because a lot of the questions that I got on the post earlier the week actually had to do with emotional regulation. Then it is the ability to have cognitive flexibility, the ability to plan, to have forethought, or the ability to think through things ahead of time, or anticipating consequences, and then learning from our consequences of our behavior, and then also organization. So those 1, 2, 3, 4, 5, 6, 7, 8, those 8 things all include under the umbrella of executive functions. Hi, Carol. Nice to see you here. Your question, do people with dementia usually end up mean? My mom, who was so sweet, is showing a mean side, and we never saw it in her before. Well, I think that is a great question, and I'm actually really glad you're here, because this goes right into the part of the emotional regulation. So executive functioning includes all of those 8 different subsets of things. And if you think about people when they grow up, when they go from an infant to an adult, they go through different phases, right? We have our infant phase where we can hold our drink, and we can drink, and then we start to sit up and hold our head up, and then we start to crawl, and then we walk, and then we start to get bladder control. But when we're 2 or 3 years old, we don't have a really good inhibition switch. We don't have a really good way of regulating our emotions. And so we'll talk about that again in just a second. So, people then develop through further phases where they then start to be able to manage their bowel and bladder, where they can dress themselves. They may not get dressed appropriately. They may be picking the wrong clothes, but they can get dressed. They have the behavior, children have the behavior of, I want to wear this. This is my favorite shirt. Don't make me take it off. I don't want to take a bath. I'm not dirty. And then we kind of grow up a little bit more where we start to go to the fridge. We can get something to eat or drink. We can do some things for ourselves, but we need supervision because we cannot anticipate consequences. We don't see what's going to happen next. And so if we look at our developmental process of people going from an infant to and our cognition, actually, I don't know if you guys know this, but actually only stops developing at the age of 25, which I think a lot of people don't realize. And this is one of the reasons why young men have a lot higher insurance rate initially until they hit 25, because the later part of our development includes this ability to be able to anticipate the secondary consequences of the things that we're going to do. So up until 25, people actually still are developing their cognitive faculties, and that is why insurance companies, through all of the research they've done, have shown that these people, they become safer after 25. Well, that's when our cognition is actually fully formed. So not 18 when we start to vote, or 21 when we're allowed to drink or get our concealed weapons permit or anything like that, but actually 25. And a very depressing thought, it starts to decline at about 40. So I just turned 50, so I'm already in the declining phase. But back to, I'll start with Carol's questions since she's on here live. So do people with dementia usually end up mean? My mom, who was so sweet, is showing a mean side that we never saw in her before. So this goes exactly into emotional regulation. It's one of the executive functioning things. So there are two ways of looking at it. When people are more even-keeled, when we can control our when we can regulate our emotions, we have what's known as an internal ability to control it. So things bounce off of us. So when we wake up in the morning, we're in a good mood, and we go to we go out and something happens, and we're able to say, oh, it wasn't me, it was them, it was the situation. That's called, we can internal locus of control. So as people start to lose their abilities to do things, and as our executive functioning starts to decrease, which is what happens in dementia, we start to lose our ability to actually control our own emotions. And then that's called having an external locus of control. So people become very socially inappropriate. They lose their inhibition switch. They will be, we all have a filter. Most of us have a filter, and if we're honest with ourselves, we're really glad most people cannot always hear what we're thinking about them or what we're saying about them in our mind. But we have the ability to regulate our own behavior, and we know it's not socially appropriate to say what we're thinking. When you start to go through this process and you lose your emotional regulation, you actually lose that filter, and so people start to become very socially inappropriate. They will say whatever's on their mind, whether it be suitable to the situation, whether it would be suitable to the circumstances, whether it would be suitable to their personality before. If we're honest with ourselves, we all have a side to ourselves that most people cannot see or don't see. And even though we all do this, everybody does this, we all put up a socially acceptable front to people that we're using our good emotional regulation not to show our frustration or our anger. We're angry in our mind at somebody, or we're raised not to cuss, and you slam your finger and you think something bad in your head, but you say something nice outside because you didn't want people to know. That's our internal ability to control our emotions. Well, people with dementia lose that ability. They cannot control those emotions anymore. And so, yes, people who are very sweet on the outside and very kind and very caring, all of a sudden they lose that filter. And and they're not able to socially do that anymore. And then they may start acting out sexually. They may say things they never did. Pastors who never swore a word in their life that cussed like a sailor. People who were never an angry person before, who now cannot control their own emotions, who show all those things that they did not typically do before. So it is very frustrating when we're around our loved one and we didn't know them in that manner before, for us to be acceptable. The thing to remember is they're not doing it on purpose. They really, truly don't necessarily know what they're doing. The other thing to consider is most behavior that people show is a result of something that has happened. You can call it the ABCs of behavior. You can say the antecedent, or I say before, during, and after. I think that's easy to remember. The before, what happened right before, then the behavior, what happened while, what happened. What did they show out? The temper tantrum, the mean side, those kinds of things. And then the consequence to it, which can be the negative behavior, or everybody's upset because of something mom said. So I would encourage you, Carol, if you're still on, to think back and maybe start a diary. You can start like a behavior diary for your mom, and you can, when something happens, when you see something, always go back and look what happened before that, what happened right before that. You have to be a dementia detective, really honestly, in order to be able to see how people are functioning or what happened. Because was she tired? Was she hungry? Was she thirsty? Did she need to go to the bathroom? Did somebody do or say something right before that triggered her behavior? Then you have to look at what the behavior is, and then the consequences thereafter. So I hope that was a little bit of helpful advice to you regarding your mom. Drop me a comment and let me know if that answered your question, and if not, I'd be happy to try and work on it a little bit further. So yes, and people when they struggle with emotional regulation, they become very easily frustrated, and they become very easily angered. So, trying to keep things calm and try to redirect people is probably the best thing that you can do. So here are a couple of the questions that I got earlier this week on the post that I made about what kind of questions people had. So one was, why are they great one day and then awful the next? Well, I was thinking about this one a lot during the week, and it's a really hard question to answer, because without really understanding what had happened during the week, it's a little abstract. It's very abstract. But we all have good days and bad days. We all have days when we don't feel well. I know I went up to Tennessee earlier this week, well, actually last weekend, to help my adult daughter and her husband move up there, and I got a terrible allergy attack. And if you can hear, you can still hear the residuals of that allergy attack. And so I was not having a great week for most of the week. I didn't sleep well. I had to take medicine that I don't normally take. I felt great one day. I woke up exhausted the next day because I didn't sleep. My diet was out of whack because I hadn't been home eating the food that we would normally. We had great food. The food wasn't bad, don't get me wrong, but we were out of our normal routine. And just being out of our routine, and there's, for the most part, nothing wrong with me, I had several terrible days in a row. And I'm a normal, functioning adult. I go to work, I do everything I want to do. So when we have people with dementia, and depending on their level of dementia, they are going to be just like us. They're going to have good days and bad days. Probably one of the things I see the most common in my practice, and I work still full-time as an occupational therapist in a home health setting, which has been an extremely valuable opportunity for me to be able to do this, because when I was working in the hospitals, and when I was working in acute rehab, and when I was working in all these other places, it was very easy, because the structure in the hospital, there's a routine. There's, people come to work at a certain time, people leave at a certain time, staff changes at a certain time, meals are always at a certain time. There's a very big structured routine in a tertiary setting, not at home, somewhere else. Whereas at home, our lives are a lot more fluid. And what I have found in the last almost 2 years that I've been working in home health is how little structure and how little routine people actually have in their lives with their loved ones with dementia. And I find it striking because probably one of the biggest things that's the difference between being at home and taking care of somebody when they have dementia or behavioral issues or other things going on in a facility. If you want to ask me what the biggest difference is, it's the structure and the routine of being in a facility. Facilities are very routinized, and do not misunderstand me. I'm not suggesting that you put your loved one in a facility that is a very individualized, a very unique decision. There are so many different reasons why people should or should not be in a different type of a facility. But one of the reasons that some people do better in a facility is because the facility is very structured. You get your medication at the same time every day. You get your shower at the same time every day. Your meals are at the same time every day. There is a very strict routine. And so people, when they're living at home and they have a way more fluid routine, because mom didn't sleep well the night before, now everybody's sleeping until 11 because they're trying to get rest, throws off the routine, and it can make keeping a person at home be up and down. So the probably the best advice I could give you to try to increase the likelihood of having a more even keel is try to keep the routine, the daily routine within the household if you're taking care of somebody with dementia at home. If you keep them in a very structured routine, and especially get up at the same time every single day. It's way more important for us to get up at the same time every day than it is to go to bed at the same time every day. Our body needs to have an awake and a sleep cycle, an awake and a sleep cycle. And if we keep moving the waking time up, it moves our sleeping time back. And so you want to try to be as structured as you can within your own routine in order to try to help level things out. So that could be one factor as to why somebody is having a good day one day and a terrible day the next. Also, then you got to start to ask yourself, what happened? Be like I said, a dementia detective. Write it down. On the days that are good, what's going on? What's different on those days? And then on the days that are not good, what are the variable factors? Because sometimes it could be somebody came to visit and it was too much stimulation, or it could be the other flip side of it. There was absolutely no stimulation. Maybe on the one day that they're having a good day, they were engaged in their environment. There were people coming in. There weren't maybe as many people coming in. Write things down. Diarize. Probably doing a diary, an activity diary or a behavior diary, is probably one of the best things that you could do when you're struggling to figure something out, because even just writing it down for a week would start to show you patterns, and patterns can make a big difference when you're taking care of somebody with dementia. So the second question, is there anybody else out there that has another question for me? And pop them in the comments if you need to. I'd be happy to answer them. Otherwise, I'm just going to keep talking. Let me know if anybody is out there and has any specific questions right now. What kind of signs and symptoms to watch out for a urinary tract infection? So a urinary tract infection, typically, and not everybody has this, but burning when they pee, foul-smelling urine, dark-colored pee, abdominal pain or lower abdominal pain. The biggest, probably the single biggest change in cognition for people with dementia or any underlying cognitive impairment, the fastest change, like this, overnight change in mentation can be a urinary tract infection. So if somebody is doing their norm, they're doing their thing every single day, and overnight they wake up and they're very confused and not their normal baseline, you have to stop and ask, do they potentially have a urinary tract infection? Not everybody burns when they pee. Not everybody has outside signs of a urinary tract infection. It can be entirely asymptomatic. Sometimes they have a fever. Sometimes there's blood in the urine. Sometimes there's a lot of different factors. But typically, the quickest way, or at least from the outside looking in, one of the fastest ways of seeing a urinary tract infection is that their thinking processes have changed. How to keep out for signs of urinary tract infections? You want to make sure that your loved one stays hydrated. I'd recommend that you make sure that they drink in the morning, first thing in the morning. Start to rehydrate them earlier in the day. Push fluids earlier in the day and kind of taper the fluids later in the day to make sure that they're getting enough hydration that will help to prevent a urinary tract infection. All right, and then the next question was sundowner's rage. Whoops. Oh, I see here. Sorry, I didn't scroll down and I didn't see that I had more comments. So Eunice said, Mom has dementia. Last week, Dr. said she's Alzheimer's can also can it happen. So Eunice, dementia, if you want to think about dementia, the term dementia is just an umbrella term. And underneath the term dementia, there are lots of different types of dementia. One is Alzheimer's. One is vascular. So sorry, Moira, I didn't see them come up. I just scrolled down and I will get to your question next, okay? So one is dementia, one is, so dementia and then Alzheimer's dementia, and then you have like Lewy body dementia, and then you have, I can't even think of any of them right now, but there are 4 frontotemporal dementia and Pick's dementia. There are lots of different types of dementias. So the only way Alzheimer's dementia can truly be diagnosed is on autopsy. So when doctors are telling people that they have dementia and then they say they likely think it's Alzheimer's, it's just because they are seeing certain signs and symptoms. There's certain traits that each one will have. One is vascular dementia. So dementia is the global term, and then Alzheimer's is just one of the legs of the different under the global term. So Moira's question was, can I tell you what to expect in the stages of having vascular dementia? So that's a tough question, Moira. I don't know enough about the vascular dementia that you're referring to. Vascular dementia can be either very, very slow. I've seen it be like my mom has vascular dementia. Her vascular dementia was related to having had a stroke when she was in her early 40s, and she's had lots of multiple cardiac events, not cardiac events, but like stroke type events over the years, little TIAs, which cause little damages throughout the brain. So if you want to think about the brain, and we have our blood vessels in our brain, and all of the blood vessels kind of will start to have little blood clots or whatever, and they make little pinpoints. And so the damage can be very more diffuse. It can be spread out. So when you look at somebody's MRI or CAT scan, when they have vascular dementia, it can look like a starry sky. It can be clusters of stars together, and then big black areas, which would be good, and then the little white in between. So vascular dementia can be very, very slow, like people are not having a lot of these events at the beginning, to very rapid at the end, and can be very, because they're having multiple things happen. Typically, the reason why it has to do with your cardiovascular system. People are throwing blood clots, or their arteries are hardening and they're getting smaller. So it'll still follow the same general process as a regular dementia. It's just the reason why people are changing is a little bit different than, say, people who have Alzheimer's type of dementia because of the plaques or the tau tangles or those kinds of things. The mechanism is a little bit different. But our brains, in essence, are always trying to protect one thing. If you think about what it is we're trying to protect, we're trying to stay alive. That is what the very first thing that we do when we're born is we start to breathe and our heart's pumping and all our organs are going. And our brain, and so going back to the beginning, I don't know if you were on at the beginning, as we go through developmental phases, we go from being an infant to being able to think and process and reason and do all those kinds of things. Well, as our brain, when our brain is changing and it is starting to decline because of vascular dementia, which is the blood supplies not getting to the brain, our brain starts to throw away things we don't need anymore. So the first thing to go is the new stuff, because we're trying to stay alive, we're trying to breathe. So we'll throw the things away that we don't need, and then it'll be, you kind of look at it like an onion going from the outside to the inside. You know, each layer on the outside, we'll start to discard the stuff that we don't need in order to stay alive, and the last stuff that will stay intact is our ability to feed ourselves and to eat or to swallow, to breathe, to regulate our temperatures and so on. So I don't know if that answered your question, Moira. I'd be certainly happy to answer it a little bit more fully. If you wanted to message me privately, I'd be happy to hop on a call with you regarding any other additional questions that you have regarding that. It's very, it's hard without knowing more about the particular person to be able to say, okay, this is where you are now and this is what to expect next. But I'd be happy to talk to you if you want to talk to me about that, okay? So back to I'm just going to take a drink of my coffee because I'm getting thirsty. Any other comments or questions while I'm on? I see I'm about half. I cannot believe I could just talk for 30 minutes straight without stopping. Anybody who knows me would not be surprised. All right. So the next question that was on the Facebook post that I posted earlier this week was about sundowners' rage and when to go to the emergency room. So this goes back to what we started the conversation with. Eunice, I'll answer your question after this one, okay? So sundowners is a very common thing for people with dementia as the daylight starts to go away. But the rage part of it that you're probably seeing is likely just their inability to control their emotions anymore. The only, and this is also a hard question to answer because it is very difficult to know the particular circumstances about what's going on. So whenever you get anger, whenever you get something going on, go back to the ABCs, or the BD, the before, during, and after, the antecedent, the behavior, and the consequence. See what happened right before that. Is there something that's triggering it? A behavior diary makes a significant difference. Hi, Jill. I see you on there. I will get to you in a second, okay? So when people are in a rage, the first thing to try to do is try not to escalate the situation any further back down. If whatever is making them angry at that moment, you want to give them space and don't get close enough that they can actually grab a hold of you or actually hit you. So then the next question would be, are you in a safe position? Because if it's an unsafe situation, you've got to keep your loved ones safe. Obviously, they're not in a position, if they're sundowning and if they're in a rage, they're not in a position to make a good decision at that point in time. So you, as the person caring for them, you need to make a decision. Is this a safe situation for me? Can you talk them down? Or, sometimes not talking to them will help. But can you de-escalate the situation and redirect them into something else? If not, you have to decide, am I safe? If you're alone and it's somebody who is a larger individual than you and they physically, becoming aggressive, you need to keep yourself safe, and that may mean calling 911 and getting the EMS services out there to actually help and make a decision whether or not this is a safe situation. So I cannot tell you to take somebody to the emergency room specifically, but I also cannot tell you to not take them if it puts you in an unsafe situation. Sometimes getting somebody else into the house to just see what's going on, if it's a pattern, I would be looking for what's happening before. If it's a behavior that's coming over and over and over again, sometimes people have to go to the emergency room and be admitted to a behavioral health unit to work on regulating some medication to try to keep those behaviors under control. So I know that's a tough question. I know that's a hard answer too, but I will certainly be willing to ask you if you have any more questions regarding that, just reach out. So Eunice, can they get diabetes? Anybody can get diabetes. Sometimes people are diabetic and don't know it, and being diabetic can actually increase your risk for getting dementia. There's more and more research coming out indicating that people with high A1Cs, which is the test that they do for blood sugar over 3 months to see that anybody who is testing in the pre-diabetic up to the diabetic phase is significantly more likely, and I cannot remember the percentage, but I want to say 50 to 60% more likely to get dementia if you're diabetic. But just having dementia doesn't mean that you're going to get diabetes. Thank you, Moira, for your compliment. That was real sweet. All right, so Caroline has a question. What activities are good for somebody who can read but cannot retain content? So most of the time people will get to a point where they can still maybe read words, but they cannot really remember or retain. But it's actually not a bad activity to do, and it's a subtest in the tests that we do for people with dementia, is a story recall. So you can write out a couple of stories that are short with 7 or 8 pieces of information, and maybe have them read it out loud so you know that they've actually read the question. It works on your ability to actually retain some information. So say you make up a short story. Lizette's sitting at the computer drinking her cup of coffee. It's Saturday and it's about noon, and she had a hard time getting her Facebook Live set up today, and was pretty nervous about doing this. So that's my little story. And then you go back afterwards and ask them to read the story out loud, and then say, so retell me the story about Lizette and her Facebook Live. And then you would have them retell the story so that you can try to work on them actually retaining the content. So just because somebody's not actually retaining it doesn't mean that we don't try to work on retaining it, but there are lots of activities that you can give somebody to do. Sorting things is a great way. Sometimes you need to get them started, but sorting laundry, especially if it's a female, somebody who did laundry her whole entire life, sorting laundry, sorting socks, those are good things. That's a good way to be able to do it. All right, so next is Miss Jill. Is there a timeline for the regression from time of diagnosis where people are relatively still functional to the time when people forget everyone, become incontinent, and really become non-functional? Is it months or years? Yes, Jill. So there is a timeline. And I'd be happy to send you some information on this. There are multiple different ways that you can stage somebody with dementia. So you have, if you want to think about it as a continuum, from normal cognition, which most of us have fairly normal cognition. I just turned 50 and I forget some stuff, but I'm able to recall it later. So even though I forget some things, I still have normal cognition. Then there's a period of time with what people may call subjective cognitive impairment. That is when I myself start to believe or really am having trouble remembering things. And that phase can last up to 7 years. 7 years before people even have what's known as mild cognitive impairment. You can have up to 7 years of subjective cognitive impairment. The mild cognitive impairment phase can also last about 5 to 7 years, just depending on person to person, just depending on the type of reasons for why they're starting to get trouble with their thinking. From the time of a mild dementia diagnosis, so mild cognitive impairment is not dementia yet, it is the pre-dementia phase. So from the time of diagnosis of mild cognitive impairment, that phase, depending on the scales that you look at, can be between 2 to 5 years. And then the moderate dementia scale time can also be, about 2 to 3 years, depending on the scale that you're looking at. And then the severe dementia scale, when people are really, really impaired, can be anywhere from a year to 2.5 years. I will tell you, the better care people get, the longer they live, obviously. So from initial diagnosis, it can be anywhere from 5 to 10 to 20 years. It really depends, and everybody's progression is going to be significantly different. Now, Jill, there are a lot of things, and this is something that you don't hear a lot about in the medical world right now. And I know a little bit about you. I know your background. There's a lot of research, there's a lot of new research that has come out, that there are a lot of things that we can do to prevent and reverse and change dementia, especially earlier on. The earlier we start working on those things, the better chance we have of preventing it from getting worse. So if you're interested in finding more out about that, please reach out to me, and you and I can have a conversation on the phone regarding what kind of strategies and what kind of things you need to do. The newer research is significant. If you go into the medical world, and this is one of the reasons that I'm doing the consulting that I'm doing and the coaching programs that I have, is because there's a vast body of knowledge that shows there are things we can do to change this, but the medical model is not showing that. Just like me, I'm a dementia specialist. That's the thing I know the most about. I can muddle my way through vestibular rehab and other stuff, but I really don't know that much about it, so I don't know what the newest research is. A lot of people and doctors are not keeping up necessarily with the newer research into what to do to prevent or delay the onset of cognitive impairment for people. And there's a lot that can be done, and it's really starting to show that there are 4 things, well, there are more than 4 things, but diet, exercise, sleep, stress, your inflammation level, toxicity like mold, if there's mold in the house, biological genetic factors, and the more things we can control, the better we can make our thinking processes. So that's a really short, long answer, but I hope you reach out to me. I'd love to talk to you about that if you'd like to. Whereas that, I'd imagine anybody whose kidneys are affected, or the fact being put on eating excess of sweet foods is not losing weight, could become diabetic, yes. But similarly, those who are overweight in the early stages, who have long-term bad high calorie diet, can be prone to getting diabetes, yes. So one of the things that the newer research is significantly showing is that that pre-diabetic and diabetic and high blood sugar is actually a significant contributor to dementia, and that is something we can all control. So I know you guys don't know me real well, but from December last year, which is when my daughter got married, and I was stressed out of my gourd, not eating well, not sleeping well, not exercising, and eating like a significantly different diet than I am now. And I look at photos of myself at my daughter's wedding, and I look at photos of myself at my 50th birthday, which was a week and a half, 2 weeks ago now. And in that period of time, I have changed my life. I've said, I'm more important than everything else going on around me from a health perspective, keeping myself healthy. I started following the diet because I was having what I would call subjective cognitive impairment. I was having trouble remembering things, whether it was stress related or whatever, I don't know. But I'm like, ooh, I have a history in my family. My grandmother had dementia by the time she passed, and my mom has definitely got some form of vascular dementia. And I'm like, what can I change? What can I control? So in the period from the beginning of the end of the year, my daughter got married on the 14th of December through now, I've lost more than 30 pounds just working on exactly the kinds of things that I'm teaching other people to do to try to improve their cognition. And I can tell you it works. All right, thank you for the information, Liz. Great. So we're 45 minutes into this. I can't believe this. I've got about 15 more minutes, and then I'm going to hop off. And I had another question also that had to do with the emotional regulation, which is pretty much what we've talked about a lot today, where somebody asked, why are they in a rage the one moment and crying the next? It's because they have lost their ability to regulate their emotions. Liz, what diet am I following? So one of the best diets, there are two diets that come up in the research for improving your cognition and preventing or decreasing your risk of actually getting dementia. The one is a ketogenic diet, and the second one is to stay away from all grains, the grain-brain diet. A high carb diet is not indicated. It's not great. Get your thyroid checked. You know what? I have had my, so back to Liz. I'll get back to you, Jill. And then doing intermittent fasting. Our brain actually needs some time in between eating to get rid of the junk in our brain in order for our synapses to fire. So ketogenic diet and a totally grain-free or, oh gosh, I totally forgot the word of it now. A gluten-free diet, okay? Yes, Jill, I have actually had my thyroid checked. I've had my thyroid checked multiple times, and they always tell me my thyroid is fine. And I will tell you, I don't believe it because I've always struggled with my weight. But, what can you do? I'm about ready to go to a functional medicine doctor and actually have things tested a little bit differently instead of the way the medical model does it, but to really work more on a holistic way of being treated by myself. But yes, diet and exercise, I hate that these therapists are right. Diet and exercise makes a big difference. So one of the other questions I got on the little post I put down on Facebook earlier this week was how to get somebody to bathe. So bathing is an interesting thing. As an occupational therapist, I work with a lot of people regarding bathing. And yet again, not knowing a little bit more about the particular person, it makes it very hard to answer it, specifically. But I will answer it a little bit more generally than I can. So the first thing you want to look at is the situation. If they're in their 90s, they may not have ever lived growing up with a shower. They may have only sponge bathed. They may have only taken a tub bath. They may have only bathed once a week. They may have only bathed every other day. So that, you want to know about their background a little bit more before you start to try to implement things. People go back to literally how they grew up. So if they're in their 90s and they only took a bath once a week and the rest of the time they sponge bathed, and we're throwing them in the shower and we're expecting them to take a shower every day, they may not be able to do that. Their brain just may be saying, way too much. Did they have a near drowning experience? Some people do not like having water in their face, and if we don't know that and we put them in a shower and we spray water in their face, they freak out. So there are lots of things regarding bathing. There's so much that we can say regarding bathing. One of the things that I want you to think about is if it becomes a battle, is it really worth the battle? You can be clean without taking a shower. I'm not saying they don't need to wash up, but we don't have to actually get in the shower to get clean. You can sponge bathe somebody very effectively, and they can be clean from top to toe. So you don't have to get somebody in the shower for them to be clean. The more you know about your loved one and how they grew up, the better you are going to be able to provide care for them as they're going through this process. So if you know more about, like, I would much rather take a shower than a bath, but when I grew up, that was all we took was baths. We didn't take a bath every day. We didn't have showers. In South Africa growing up, we had a tub bath, and everybody bathed. Everybody took a bath. We didn't have a shower in our house. So I don't know if I get dementia one day, am I going to really truly hate taking a shower, having water in my hair, in my face? So you want to know as much about how they grew up as what you possibly can. And then the last question I had was how to change people into changing into a good mood. So, diarize things. Probably the best advice I can give is diarize things. The more information you have, I would just write it down, and every single day, if it was a good day, what was good? What was different on the good day than on the bad day? If they're having a really, really bad day, what happened that day? Be the dementia detective. That's probably the best advice I can give you. So, really, really start to write things down. It will help a lot. Let's see if we have any more questions over here. So Liz says, thank you so much for looking after my mom is so stressful, and I know I'm not looking after myself. Yes, Liz, that is entirely true. The only comment I have regarding that is there's a hierarchy of needs. If you get that flip-flopped, you're never going to be able to do it over the long haul. The most important thing first is the household. The household has to function. You have to be able to get food, shelter, clothing. You have to be able to make sure the groceries are bought, that the laundry is done, that the bedding is changed. So the first thing is food, shelter, clothing. That's the basis. The next thing is you. You have to take care of you first, and that means you have to put structures in place so that you can take care of you. You have to be more important than your mom, or else you cannot do this long run. And then your mom. If you flip-flop this, then nothing will function. So I'd strongly encourage you to start to think about strategies and things you can put in place so that you can do this for the long haul. And if you want to reach out to me, I'd be happy to talk to you. I tried to call you a 3 weeks ago and we weren't able to hook up, so I'd be happy to reach out and talk to you. Just shoot me a private message if you want me to. And Jill says, yeah, the primary care doctors don't usually do the deep dive with the thyroid, right? And the functional medicine doctors do, yeah. Yeah, I'm definitely going to be looking at that more. And Caroline said, yes, on functional medicine, my subjective cognition got very bad right before your thyroid levels became hypothyroid. I had all the symptoms of hypothyroid long before I was diagnosed. Well, so Caroline, if you want to reach out to me too about maybe, I do have the capacity of doing actual cognitive testing to see if you are actually having trouble. So that's another part of the services that I offer. So if you wanted a cognitive test, just reach out to me privately on Facebook. You can message me. So does anybody have any other questions? I'd love you guys to reach out and ask me questions. I have had a super tremendous, wonderful time. I cannot believe that I was able to do this for about almost an hour. This going on 53 minutes. I'd love for people to reach out to me. Like I said, I'm an occupational therapist with extensive background and training in dementia. And then I work full-time still for a home health company here locally where I live. But I've also started an online consulting, dementia consulting business where my passion is to work with people and families with dementia, specifically what I call the dementia roadmap, going, from diagnosis through death, what to expect, what kind of things we can do in the meantime. I have a module I'm starting to work on planning, which is going to be on incontinence management. I've had a lot of people ask questions about how to manage incontinence. In my years of experience, the two things that put people in facilities over time is bowel and bladder incontinence and not being able to manage that well at home. And then the second thing is the negative behaviors and not being able to manage those at home. So over the next several weeks, I'm hoping to make this a weekly thing. I'm hoping to do this every Saturday afternoon around noon. I'm hoping to start inviting some other friends and colleagues and people with experience in dementia and doing like a little interview. My purpose and goal with this is truly just to serve you and to give you a forum to ask the professionals some questions and be able to get some reliable information out to you all. So yeah, Parkinson's, my granddad had Parkinson's, Liz. Parkinson's dementia is a little bit different than like Alzheimer's dementia. It comes from a different reason, but a lot of the ways that it presents is the same, so we can certainly talk. I have had a blast. I think my voice is going. I think my brain is going. So I'm going to log off here in a minute unless anybody else has any more questions real quick before I log off. And I thank you guys for coming on. This was super fun. I cannot believe that I really enjoy doing this and it doesn't bother me to sit here in front of a computer screen and talk for an hour. But anyhow, so I'll give it a second while I take a drink. And for anybody earlier on who had put down their replay, I will send out the replay later. I do have a Facebook channel too. It's under Think Different Dementia. And the reason I picked that name for my company is because I want people to think differently about dementia in all sorts of ways. I want people to think differently about that there are things that we can do to improve our thinking, that there are things that we can do to control what happens to us. I want people to think differently about how to care for people with dementia. I want to provide people with the tools for how to do that. And so I want to give you all a wonderful shout out. Thank you for being on here. Thanks, Liz. Thanks, Eunice. I will be happy to talk to anybody. Caroline, Joel. I know that Moira was on earlier. So thank you guys for sticking with me today. And Eunice and Mike hopped on. I'm pretty sure he hopped off again. But I thank you guys for joining me this afternoon, and I look forward to serving you more in the future. Please reach out to me. My name is Lizette Cloete. I'm an occupational therapist, and I'm pretty active here in the group, so just reach out, and I look forward to speaking with you. Thank you. Bye.